All right, let's jump right in. We're going to do a super quick, high-yield rundown of the essential ACLS drugs. But look, this isn't just about memorizing a list. To really get this stuff down, you got to know the dose, the timing, and most importantly, why you're giving it in the first place. So let me ask you a question right off the bat. When you're in a full-blown cardiac arrest, what's the single most important drug you can possibly give? Just think about it for a second. What's your go-to? You got an answer? Well, here's the twist. The most important life-saving intervention isn't a drug at all. And getting this concept is absolutely critical because it really frames everything else we're about to talk about. The real stars of the show, the true foundation of any resuscitation, are these two things right here: pushing hard and fast with high-quality CPR and getting those pads on for early defibrillation. The drugs? Yeah, they're powerful, no doubt. But think of them as the supporting cast. Their main job is just to make our CPR and our shocks work even better. Okay, so with that crucial foundation set, let's get into the pharmacology. And we're starting right where the pressure is at its absolute highest, the drugs you use when the heart has completely stopped. First up, the one everybody knows, epinephrine. But I want you to completely reframe how you think about it. It's not some magical heart starter. It's a perfusion booster. Its entire purpose in a code is to make your chest compressions more effective. That's it. And the protocol? It's beautifully simple. The dose is always 1 milligram, given IV or through an IO. And the timing is what's absolutely key here. You repeat that same dose every 3 to 5 minutes for the entire duration of the arrest. No complicated math, just simple, consistent repetition. So here's the why. How does it actually work? Well, we're really after its alpha effects. Epinephrine basically clamps down on all the blood vessels in the arms and legs. That forces all the blood back to the core, which jacks up the blood pressure, and that is what allows your chest compressions to actually push blood into the heart muscle itself and up to the brain. Okay, so picture this. You're doing great CPR, you've pushed epi, you've shocked the patient, but the monitor is still showing that chaotic, useless rhythm, VFib or pulseless VTach. What's next? Well, this is your moment to reach for what I call a chemical defibrillator, Amiodarone. Now, the dosing here is specifically for those rhythms that are refractory, meaning they just won't break with shocks alone. The first dose is a big one, a 300 milligram bolus. That's just a fast push. If the rhythm persists, you can follow it up with one more, smaller dose of 150 milligrams. Now, you might be thinking, hey, what about Lidocaine? Good question. The difference is really in how they work. Amiodarone kind of lengthens the heart cell's reset time, which helps calm down all that electrical chaos. Lidocaine is a bit simpler. It just kind of numbs the irritable parts of the ventricle. Because amiodarone has a broader effect, it's usually the first choice. Okay, let's totally switch gears. We've talked about cardiac arrest. Now let's move into scenarios where the patient does have a pulse, but their heart rate is either way too fast or dangerously slow. So if the heart rate is crawling along and it's causing problems, low blood pressure, dizziness, we call that symptomatic bradycardia. And our first-line drug here is atropine. Think of it this way. There's a nerve called the vagus nerve that acts like the brakes on the heart. Atropine basically cuts the brake line. The dose is 1 milligram IV. And hey, does that timing look familiar? Just like epinephrine in a cardiac arrest, you can repeat it every 3 to 5 minutes to try and get that heart rate back up to a safe level. But, and this is a big one, there is a hard stop. The total maximum dose you can give is 3 milligrams. Why? Because once you've given 3 milligrams, you've fully blocked that vagus nerve. Giving any more won't provide any extra benefit, and it just starts to increase the risk of side effects. All right, now for the opposite problem. A heart that's stable but beating way, way too fast in a rhythm called SVT. The drug here is adenosine, and it's basically a chemical reset button for the heart. But here's the catch. Its half-life is literally just a few seconds. That means if your technique isn't flawless, the drug is gone before it ever reaches the heart. This is where the 2-syringe technique is so critical. You have to push the initial 6 milligram dose as fast as you humanly can, and in the exact same motion, immediately slam a 20 milliliter saline flush right behind it. Then get that arm up in the air. Seriously, that saline flush is just as important as the drug itself. It's the rocket fuel that gets the adenosine to the heart in time. Let's talk about a more specialized drug for a minute, magnesium. This isn't your go-to for just any old arrhythmia. It's a specialist. Its main job is to stabilize the heart cell membrane, and we really only use it for a very specific, dangerous rhythm called torsades de pointes, or if we know for a fact the patient's magnesium level is low. The dose is pretty straightforward, usually 1 to 2 grams. But, and I need you to really look closely here, check out that confusion time. This is where people get into trouble. I cannot stress this enough. Unlike adenosine, which you push like your life depends on it, you have to give magnesium slowly. If you slam magnesium, you will cause the patient's blood pressure to completely tank. So one drug is a lightning-fast push, the other is a slow, controlled drip. Know the difference. You know, sometimes the heart problem you're seeing is actually just a symptom of a much deeper issue, like a specific type of overdose or a crazy electrolyte imbalance. And that's where these specialized drugs come into play. Now, these are not for every code. You'd only think about giving sodium bicarb in very specific situations, like if you know the patient overdosed on tricyclic antidepressants. Same thing for calcium. Its job is to protect the heart from dangerously high potassium levels or a calcium channel blocker OD. These are sharpshooter drugs, not shotgun blasts. And finally, we get to the moment you've been fighting for. All your work pays off, and you get a pulse back. We call this ROSC, or return of spontaneous circulation. The second this happens, the entire game changes. We shift from these emergency bolus pushes to really careful stabilization, usually with continuous IV drips to support blood pressure and prevent the heart from arresting again. And this quote right here, it just perfectly brings it all home. You can be a walking encyclopedia of pharmacology, know every dose, every mechanism, but at the end of the day, these ACLS drugs are just support systems. They exist for one reason, to make good CPR and fast defibrillation even more effective. So all this knowledge we just covered, that's your toolkit. It's ready to go. But this slide asks the only question that truly matters. The toolkit is ready. Are your hands? Because in the heat of the moment, it's the hands on the chest that make all the difference in the world.